So today we're going to talk about myasthenia gravis, but only one piece of myasthenia, which is trying to differentiate and recognize the born with it forms, the congenital forms, from the one you're more likely to encounter, the acquired forms. So the acquired forms are autoimmune because we have antibodies, and those antibodies binding, blocking, modulating LRP4, a whole host of different antibodies, affect the neuromuscular junction by binding to the acetylcholine receptor and affecting its function. So the acetylcholine receptor antibody, an autoimmune acquired cause of myasthenia gravis, and because the thymus is involved in modulating the T-cell immunity and affects the antibody production, patients with acquired myasthenia gravis have a CAT scan of their chest to look for thymoma. And even if they don't have a thymoma, if they just have thymic hyperplasia, or if they have nothing on the CAT scan, we can still take it out. And the thymectomy might cure myasthenia gravis. We generally reserve the thymectomy for generalized myasthenia gravis, not just ocular myasthenia gravis. And of course, the typical presentation, variable and fatigable ptosis and ophthalmoplegia, diplopia, can mimic any pattern of painless, pupil-spared, non-proptotic ophthalmoplegia. You should be thinking about myasthenia gravis. Even if it looks like a third or a fourth or a sixth, it can always be myasthenia. So if it's painless and pupil-spared, non-proptotic, you should be thinking about nerve, muscle, and junction. And in myasthenia, we're going to be ordering the antibodies and doing a CT of the chest. You can do ICE tests for the ptosis. You can do tensilon, prostigmine tests, all sorts of different things. Single fiber EMG is actually the most sensitive, but it's not universally available. And of course, the treatments, because it is autoimmune disease, mestinon for the acetylcholine receptor, but mestinon doesn't affect the antibodies, and so we need steroids or some immunosuppressive therapy. Steroids tend to work better for ocular myasthenia than generalized myasthenia. In contrast, the congenital forms, you're born with it, congenital, so it's a childhood onset rather than an adult onset. And it's not autoimmune, so there's some sort of genetic defect either in the presynaptic, the synaptic, or the postsynaptic acetylcholine receptor. And so immunosuppression is not given for the congenital myasthenic patients because it's not an acquired autoimmune thing. We're not really worried about thymoma, but the presentation is similar. Childhood versus adult, but variable, fatigable ptosis, ophthalmoplegia. Congenital cases with generalized disease have generalized symptoms that are potentially dangerous, including speaking and swallowing difficulty. They can get aspiration pneumonia or go into respiratory failure. You should know that some of the congenital forms, the traditional treatments, pyridostigmine, anti-acetylcholinesterase, might make it worse. So you should be thinking about congenital in patients who have childhood onset, who have no autoimmune antibodies, do not respond to traditional therapies like mestinon. We don't give autoimmune immunosuppressive treatments to the congenital forms. You need to recognize there are presynaptic, synaptic, and postsynaptic forms, and you can test for those. And we don't have to worry about thymoma in the congenital form.